Okay, thank you. Today we're going to talk about child abuse, and particularly as it relates to pediatric brain injury, and particularly as it relates to kids mostly under a year of age, sometimes up to 2 years of age. But most of the abusive head trauma that we see is in the very younger children. My disclosure is that I have book royalties that I receive, and otherwise the class has no commercial support or sponsorship. The objectives today are to look at the terminology, the origins of the term shaken baby syndrome and abusive head trauma, describe signs and symptoms of abusive head trauma, identify the long-term effects of abusive head trauma in infants, and synthesize the importance of abusive head trauma prevention in your own practice. So for years we used the term shaken baby syndrome, and this was because early on some very famous cases actually. One particular was a nanny in Connecticut who had probably 12 children that she killed or severely injured, and she said, I would just shake them really hard when I got angry at them. And people started recognizing that retinal hemorrhages and subdural hematomas and bad encephalopathy was associated with shaking. But then it turns out that shaking's really bad for kids, but so is impact on babies' heads. And sometimes we don't know what the mechanism of injury was at the time that we're standing at the bedside. So shaken baby syndrome implies a mechanism. And so rather than implying a mechanism, the Academy of Pediatrics recommends that we use the term abusive head trauma, because that includes shaking and impact. And certainly it does not in any way take away from the fact that we want to be sure and educate parents about the dangers of shaking babies. So we see sometimes, in addition to brain injuries with shaken baby syndrome, fractured bones and injuries to other parts of the body. Okay, we talked about that. Now I'm going to talk about abusive head trauma throughout most of this talk. In the USA, it's actually a very common cause of death and disability in children. How many have actually taken care of a baby that has abusive head trauma? Yeah, just about everybody. Children under 2 are the most vulnerable, and it's estimated that 2,000 to 3,000 children die each year from child abuse in the USA, and most of those are head trauma cases. Most of the kids that die because of head trauma. Why are infants so vulnerable? Well, they have no ability to protect themselves. They have very large heads and very weak necks. They can't tell anybody they're being harmed. And literally every case I have done, and I've done hundreds of these cases over the years, if people tell us what happened, they all say the baby just was crying and crying and crying, and I couldn't get the baby to stop crying, and I just lost it and shook the baby or slammed the baby or both. But, you know, crying is baby's only mechanism of communication. And so this makes them vulnerable. If they're unhappy, they can't tell their caretakers they're unhappy. And some people are just really not very tolerant of crying babies. So when we talk about abusive head trauma, I think that, you know, the dura mater is very important, that lining inside the skull. And in babies and young infants and very young children, the dura is very tightly attached to the skull. At autopsy, you literally have to just, you know, really pull on it to get it to come off. So we don't really see epidurals very often in infants, but they're usually accidental. There rarely are epidurals associated with abuse. Now, that means if somebody whacks a kid over the head and they get bleeding between the skull and the dura, you know, that's abuse. And so, but most of the kids we see with epidurals are not abuse cases. And that's just a nice picture of the dura that I happen to kind of like. When we talk about the different types of head injury, we kind of like to think of this as I like to think of the brain as an onion. So you have the scalp and the skull, and then here's your epidural outside your dura, your subdural under your dura, and then, of course, brain contusions and hemorrhage in the brain itself. Okay, epidural is not likely to be from abuse. But in infants, particularly under a year of age, subdural hematomas are mostly caused by abuse, not all. We see kids who have, people who drop their children on an icy day when they slip on the stairs, and they end up with a skull fracture, and below the fracture there'll be a small contact subdural that just from the contact, from the impact to the head. But when we see kids with very large subdurals, extensive subdurals, bilateral subdurals, those are much more likely to be associated with abuse. Subdural hematomas occur because we have these bridging veins that collect blood from the brain, and then they dump it into the venous sinuses to be carried back to the heart. And those bridging veins are vulnerable to tearing with either severe impact or shaking. Here's just a picture. Can we dim the lights a little bit? Dim the lights a little? Hello? Lights? Okay, whatever. Oh, thank you. So here is these bridging veins run from the dura, which in the infant is tightly attached to the skull and to the brain, and so it runs through, quote, the subdural space. Now, in health, there is no such thing as a subdural space. The dura and the arachnoid are cheek by jowl, and they're very closely related. But when the brain moves back and forth in the head, either through impact or through shaking, you get these bridging veins will shear, and into the space, the potential subdural space, the bridging veins then bleed, and you get your subdural hematomas. Here's just an example of a subdural at autopsy in one of my fatality cases, or I'm sure you've all seen subdurals in imaging studies on kids that you've taken care of. Okay, small subdurals can be caused by contact injury and short falls, but again, extensive bilateral, midline, posterior fossa subdurals, those are more likely due to abuse. By the way, about 40% of babies will get subdurals at birth. And those can persist for up to 4 to 6 weeks. They're not symptomatic, and they've only been found when people were doing MRIs for other studies. They realized that, in fact, subdurals are not uncommon, but they're almost all in the posterior fossa, which with our child abuse cases, you're going to find them up around the temporal area mostly. So they really don't look like the kinds of subdurals that we see in child abuse. So again, when we see posterior fossa subdurals outside of the newborn period or the neonatal period, that is very concerning because most accidental injuries, we don't see posterior fossa subdurals. But if you pick up a baby and violently shake them, you're going to tear vessels not only in the upper parts of the head, but you're going to also get that posterior fossa. These are more likely to be due to abuse rather than an accident. And so here's an example of a child who has these midline subdurals, which are, again, pretty uncommon in accidental injuries, but they tend to bleed right along that place where those bridging veins tear as they go into the venous sinuses. And here is a classic abuse case. You can see there's subdural blood, and there's also subdural blood in the posterior fossa, which is really unusual in accident cases because the posterior fossa is pretty protected. Okay, now what we're really worried about, though, I mean, we can fix subdurals, you can get rid of them, but what we really worry about is the brain injury that is associated with abusive head trauma. And we think of this as primary brain injury and secondary brain injury. And primary brain injuries include contusions of the brain or bruising of the brain, like this child has. You can see these essentially contused areas from multiple impacts to the head. It also includes gray-white matter shearing tears, and you know that the brain consists of two different types of tissue, gray matter and white matter. White matter is much more dense than gray matter, and when the head is rotated rapidly, you can actually shear right at the junction of the gray matter and the white matter. I tried to make visual to use in lectures, and I was in my kitchen and I had a layer of very thick Jell-O that was green and then a thin Jell-O that was white, and then I shook it and ended up getting Jell-O all over the ceiling. So that didn't work so well, but you get the idea. So the brain separates at the margin of the gray and white matter because they're traveling at different speeds because of their different densities with shaking or with severe impact. And here's an example of, again, one of these gray-white matter shearing tears where you actually end up with a separation between the gray matter and the white matter, leading to these kinds of holes in the brain. This is another one that was, you can see that this one has a large area of separation there and one there as well. And this is a child that died in a confession case of shaking, and you can see that the gray matter and the white matter have separated in this particular child's case. The other primary brain injury we see is the diffuse traumatic axonal injury. And you all remember that nerve cells have cell bodies at one end, and then the axons travel long ways through the brain out to the presynaptic terminals, which hook up with the dendrites on somebody else's cell body. And those axons are what seems to get injured when you have a rotational or acceleration-deceleration injury of the head. And by the way, in babies, they don't have much myelin. Their brains are not myelinated. And in adults that have diffuse axonal injury, that injury is more likely to occur right at the node of Ranvier, where the coating, the insulation on the axon the myelin is not present. So you think of a baby with very little myelin on the axons, they're going to be much more vulnerable for axonal injury than adults. So stretching of the axons leads to functional failure. They don't actually tear, but their function stops. I like to think of it like if you have trains going out of a station and they come to the point where the bridge is washed out and they'll just kind of plop down there. You have the neurolemma, you have the material that's carrying the impulses going down the axon, and when that axon fails, you have accumulations of that axonal material that we can see on stains in autopsy specimens. So you have material going down the nerve cell collects at points of failure, and again, we can use regular stains if the child's been alive for at least 48 hours. You have to use specialized stains like beta amyloid stain if the child dies within an hour or two of the event. And here's an example of an H&E stain, but on the stains you see these cotton balls. You see they look like cotton candy, and that's a site of failure of axons where the material collects because the axon has failed. So diffuse traumatic axonal injury is associated with rotational forces applied to the head, and it's associated with decreased level of consciousness. So when we have patients whose head is stable and is not set in motion, they don't lose consciousness. And I've seen kids that got their heads run over by vehicles and get smashed. They come into the ED screaming because to get to the deeper levels of the brain and lose consciousness, you have to have a rotational movement. And you can watch this if you watch NFL football games. Now that they've kind of cleaned up the games, it's not nearly as interesting for me, because it's kind of like biomechanics lab. My husband watches the games and I watch the injuries. But what you'll notice is I keep thinking of Steve, somebody or the other, a quarterback with 11 concussions in San Francisco. What's his name? Steve? Huh? No, he's an older guy, and he's been retired for about 10 years. Anyway, he had 11 concussions, and his last concussion I actually saw on television, and that was before the days when we could record things really quickly. But you could see he got hit by a big guy on this side, and his head swung this way, and a big guy on this side, and his head swung that way. His head hit nothing, and he was out cold. And the same thing with boxers. The way that you get a knockout is to go and set the head in rapid motion. So if the head is not set in motion, you will not lose consciousness initially. You may die, but you won't lose consciousness because that rotational movement has to be there to to get decreased levels of consciousness. So those are the primary brain injuries. And then, of course, the secondary brain injuries are the things that you all deal with all the time, i.e. the cerebral edema that occurs, the increased pressure that occurs because you have you have changes in circulation of the brain, and you also have swelling of the brain. And so when we see a kid like this is a baby that came in after a bad abusive head trauma episode, and you get these large areas of big black brain, that's not good. That's going to be a very, very bad prognosis. So we worry about cerebral edema, and this is a case where the cerebral edema actually led to herniation, and you get those tonsils getting stuck down in the top of the in the top of the spinal cord, and you end up then cutting off blood supply to the brain. In addition to that, you get anoxia. And I think this is one of the things we know is that abusive head trauma outcomes in infants and small children are much worse than accidental outcomes, even car wrecks. And I think one of the reasons is that if you're in a car wreck, the person behind you calls 911 and, 3 or 4 minutes later, somebody's resuscitating you. If you abuse your baby and shake them violently or slam their head, you often put them down and then leave in hopes that they'll wake up. And I've actually had parents tell me that they've learned when the baby won't sleep, if you shake them, they kind of fall asleep, i.e. they're losing consciousness. But the point is that because there's a delay in seeking care, that brain gets anoxic, that brain then gets destroyed. Whereas in an accidental injuries, usually some type of resuscitation occurs. The other kind of destruction we see is the brain cell destruction by toxic chemicals that accumulate in the injured brain. Chemicals are released by dying cells, which then are toxic to the living cells next door, and those cells die, and those cells die, and those cells die. This cascade of cell death is something that people have been trying to figure out ways to stop that cascade, because if we knew how to do that, we could have probably much better outcome in head injuries. People have tried lots of different types of biochemical things, cold, cooling of the patient, and so on, to kind of slow down that toxic cascade. We haven't been real lucky with that so far in terms of finding out a way to really stop that. So when we talk about shaken babies, we talk about violent whiplash injury caused by shaking, sometimes followed by an impact. And the thing I think that's devastating about shaking in babies is everything gets hurt. The entire brain is affected. I mean, I've had kids that I've seen at age 2 months that are slammed against a bedpost, and they come in with a huge skull fracture and brain herniating out under their skull, and in devastating shape. And then 15 years later, I get a call from one of my fellows who was with me at the time I did that case, and he says, "You'll never guess who I saw. I saw so-and-so." And I said, "Really? How is he doing?" And he said, "Well, he came in for his football physical." Now, if I had a kid with a brain injury at age 2 months, I don't think I'd let him try out for football. I think I'd encourage them to be swimmers instead. That was not a good choice. But the point was, he was walking, talking, and really had gotten, you get more plasticity, you get more ability to recover from an impact injury because you don't have the whole darn brain ruined the way you do when babies are shaken. Okay, retinal hemorrhages are very, very critical in these cases. Retinal hemorrhages are seen in lots of different medical conditions. If you climb to 10,000 feet, you'll probably have a few retinal hemorrhages. Simple falls can cause a few retinal hemorrhages. Clotting disorders can cause retinal hemorrhages. But the kinds of retinal hemorrhages we see in babies who are violently shaken are very different than other retinal hemorrhages. They're in multiple layers of the retina. As you know, there's 11 layers there, and they occur below the retina, within the middle of the retina, above the retina, actually out into the vitreous, and they're extensive. They go from the back of the eye, from the retina, all the way around to the pupil, and and the area there is called the ora serrata. So the entire eye is affected. So that's why when we see these kids they're in our ICU, we want to get the ophthalmologist in as soon as possible, because when you use that just handheld ophthalmoscope, you see a few millimeters of the back of the eye, but you can't see the entire inside of that eyeball. And that's what we need to see, because if we see retina hemorrhages that go all the way out to the periphery, that we know is much more concerning for abusive head trauma. And this is just an example of what these can look like. You can see that there's intraretinal hemorrhages, there's pre-retinal hemorrhages, and this is what we call a retinoschisis, where the retina actually separates and you get a cavity that fills with blood. And these are pretty dramatic, and there's very few conditions that we'll see this in. Kids who are dying of leukemia might have these kinds. Kids with horrible bleeding disorders might have this kind, and kids in huge major accidents. But you're not going to see this in kids that roll off the couch. That's a real tip-off that something else has occurred. That's just another example. And here, this is the eye has been cut in half. Here's the lens, here's the optic nerve. Here you can see how these go all the way out to the ora serrata, and that's very important. The other thing that's important is you actually can get retinal folds. The retina can actually pull off the back of the eye and fold up, and those retinal folds are also very important in terms of looking at some type of severe force applied to the baby's head. So you can get optic nerve sheath hemorrhages, although those are less specific. You do see those in other conditions. We get retinal detachment. I actually saw one child that where the optic nerves actually pulled off the back of the eye. They went to enucleate the eye, when it wasn't doing anything, and they found that there was no optic nerve. It was gone. It had retreated back into the head. And here's just an example of an MRI where we happened to pick up the detached retina in the MRI. Okay, and these are the optic nerve sheath hemorrhages that go down the optic nerve as it goes into the brain. So, when you have subdurals plus severe extensive retinal hemorrhages with or without gray-white matter shearing tears, diffuse axonal injury, other injuries to the body, child abuse is going to be the most likely diagnosis. Because if his child's in a major automobile accident, somebody knows that history. But the baby who's just found down, is not going to look like the child that has the brain injury from the automobile accident. So the history is critically important. The other thing that we're starting to figure out is that neck injuries are important. Cervical spine injuries. Subtle changes occur in the infant neck after shaking that may cause hypoxia and affect the outcome. Bleeding and axonal injury actually occurs at C1 or right at the junction of the brain and spinal cord. Figure if you're being shaken or your head is whipping back and forth, that's a part where there'll be hypermobility of the spinal cord and can cause injuries. And here's an example of these very subtle injuries that you can see in the cord. We didn't know that they were there until recently, because usually the easy way to do an autopsy is to cut the base of the spinal cord at the base of the brain, pull the brain out, and then flip the patient over and take a look at the spinal cord. But what you have to do to see these and preserve this area is a very extensive dissection where you actually start on the back and you loosen up all the nerves and all the nerve roots in the spinal cord, and then pull the spinal cord and brain out as a single object. Because then if you take sections right at C1, you're going to find these very subtle injuries that probably, they're not big enough that we usually don't see them on MRIs or CTs. Well, you don't never see them on CTs. You wouldn't see them on MRIs. But here's an example of a specimen from a top of the cord of a baby, and you can see that there's bleeding within the cord, and there's also bleeding in the spinal nerve roots. And that's a real tip-off that baby has had acceleration, deceleration forces applied to the head. Okay, and this is the person who developed this particular technique is a famous neuropathologist named Lucy Rourke, who work Adams, and she looked at 41 infants who died of abusive head trauma, and 71% had cervical cord injuries if you use this special technique to harvest the cord. 6 of the children with abusive head trauma had no evidence of impact to the head. They all 6 had primary spinal cord injury. None of the children had spinal fractures, but 6 of the 29 had ligamentous and muscular neck injuries, and 46% had brainstem injuries. So the low brainstem, high cord, there's a lot of respiratory centers there that are helpful in maintaining blood pressure and respiration. And so I think these subtle injuries, high in the cord, low in the brainstem, can then lead to this prolonged apnea that we often see after babies have abusive head trauma. And that, I think, may account for that big black brain that we see in the kids that have such bad outcomes. Okay, what do we know about the onset of symptoms after violent abusive head trauma? Well, what you see is an evolution of symptoms, and the evolution, it really depends on the severity of the initial injury and the nature of the initial injury. So you start off with your injury. Everybody who's ever told me what they've done says the baby looks stunned and goes, that's universal. That's what people describe. And when people say, I'm holding the baby in my arms, and all of a sudden the baby goes, and starts gasping in this very strange way, and looks stunned. I think it's like maybe a fight or flight response. I'm not sure. But, that makes me worry that that's when the injury actually occurred. That leads to altered breathing, decreased level of consciousness, vomiting, convulsions, coma, death. And again, how far down that pathway you go depends on how bad that initial injury was. Oh, let's see, what else? There's something else I wanted to. So anyway, the other thing that I think we should remember is that it's hard to diagnose abusive head trauma in babies. The younger the baby, the harder it is, because neurologic exams are not very specific. And we did a study when I was in Denver where we looked at all the kids who came in with the diagnosis of abusive head trauma, and we identified that 31% of them had had a previous episode of trauma where they were symptomatic, where they had findings on CT scans that were consistent with previous trauma, or where there was a confession of multiple traumas to the child's head. And those families were sent home with diagnoses from everything from anxiety. A baby that was that first day at daycare came home very vomiting and very lethargic, and they said the diagnosis was anxiety. Had another kid who came in with swollen lips and was vomiting, baby, and she got sent home on Benadryl for an allergic reaction. By the time she came back after she had a cardiac arrest an hour later, her lips were blue. She had obviously been hit, and she had horrible brain injury. So it's really hard in little babies to diagnose this. So you just have to at least think about it. And the group in Pittsburgh that's done quite a bit of research on this says the one tip-off is kids with vomiting, babies with vomiting, acute onset of vomiting without fever and without diarrhea. At least think about that as a possibility that there may be something going on in that baby's head. One of the things, too, is that oftentimes this happens to kids multiple times, and after the first event, they can kind of get better. Like a day or two goes by, and they kind of wake up, and they feel pretty good, and they start looking normal until it happens again. And I did a case where, again, it was a confession case where they told us what happened, but mom went to work on Thursday, and dad couldn't get the baby to go to sleep and shook the baby real hard. This is at 10 in the morning. Baby, this is a 6-week-old. So mom got home at 10 at night, and he said, baby just ate, when in fact baby had slept all day, 12 hours, and continued to sleep through the night, which was the first time the baby had ever done that. The next morning, baby woke up, and mom said, there's something wrong with him. He's just not himself. I don't know what's wrong. I can't really tell you what it is. And the dad kept saying, oh, maybe he's getting a cold. Don't worry about it. Don't worry about it. And this went on all day. Late at night, Mom was still very concerned. She took the kid to the hospital, to an ED. And the ED note, unfortunately, was very brief. And it really wasn't very helpful, except the person who did the exam said, oh, this is just a nervous first time, Mom, and sent the baby home. According to Mother, the baby did not look good to her until this was on a Thursday, until Friday, Saturday, Sunday. By Sunday night, he started to perk up and look like his normal self. So he started to look better. Monday, Mom goes to work. Dad shakes the baby. Baby dies. One of the things we know about head trauma, it's kind of like concussions in athletes. If it happens, the second hit is much worse than the first hit. There seems to be a cumulative effect of multiple hits. And I've had people say, well, I shook him, 4 or 5 times and he was okay. And the 6th time I shook him, he died in my arms. So there's some kind of cumulative trauma that tends to, and this has been shown in animal models, that if you take a piglet and you shake them real hard or cause a bad head injury and then sacrifice them at the end of a week later, they'll look pretty bad. But if you do it twice and sacrifice them, they'll look really bad. So there's something about those multiple events that actually increase the likelihood that you're going to have bad trouble. Okay, how about prevention? Unfortunately, there's no vaccine to prevent abusive head trauma. Educate, educate, educate is all I can say. At this point, we've not found the magic bullet. Certainly, a lot of hospitals are doing postnatal in the maternity ward, doing education called Period of Purple Crying. And what this does is tell parents it's okay to let kids cry. Don't get angry. If you're upset and you feel like you're going to hurt the baby, put the baby down. Or here's other things you can do to soothe the baby. So talking about crying, reinforcing education about crying is very important. And I think it's important not to just do it after delivery. I think it's important to keep doing it and keep bringing it up. And I think a lot of the babies we see that get really badly injured are not injured by their moms. They're injured by dad or mom's boyfriend or a teenage babysitter. So, and those people often don't get this education because they're not sitting in the maternity ward. They're not going to well-child visits. So I always tell parents to be sure that anybody you leave your baby with knows about the dangers of shaking and impact. Explain the issues with the very weak neck and how they can't protect their head and how important it is to protect that head-neck unit in infants. So that's something that parents have to take some responsibility for in terms of educating other caretakers. It's okay to put a baby that's crying down and call for help if you're losing control. And again, talk about that vulnerable head-neck complex in infants. Okay. Oh, I forgot to put I said I was going to talk about outcome. And I didn't put a slide in. I'm sorry I didn't. I usually do. Outcome. It's much worse than an accidental head trauma. Most of the kids that, we do a really good job now of saving these kids. Our ICUs are so effective. But the kids that we send out are usually pretty devastated. About 20% die, and about the rest of the kids, about 3/4 of the rest of the kids are going to have very severe, obvious disability in the first year of life. They're going to have CP. They're going to have gastric tubes. They're going to have severe developmental delays. And even the kids that look good when they leave the ICU, when we see them back, in kindergarten, they've got ADHD, they've got poor impulse control, they're having learning difficulties. There's other things. They look worse as time goes on instead of looking better. And so I think some of the faculties that they lose are these higher centers, these higher functions. You don't do calculus when you're a baby, and you don't talk, you don't walk, and you can look pretty good when you leave the ICU. But those kids are mostly going to have pretty bad troubles when they get older. Blindness is another big one. Central nervous system blindness. So at least I talked about it, even if I forgot the slide. Okay, any questions?
My question is around a neck injury. So it sounds like on autopsy you can see evidence, but I'm wondering if physical assessment kid comes in and you see retinal hemorrhaging on imaging and you can see bleed with imaging. Is there how does that fit into the triad when you're doing a live
Well,
assessment?
this is very interesting because we have a new radiologist on our staff who says, "Hey, I came from Hopkins, and every baby that came in with suspected child abuse came in a collar, and they stayed in a collar until we were absolutely sure." Now, most of those kids are not going to have osseous injuries. The only way we're going to see an injury is on MRI. Those cord injuries are so subtle; they probably, unless you just took incredibly small cuts, you're probably going to miss them. Although now we're trying to get people to do neck MRs on every baby, and it's amazing how often we'll find some soft tissue swelling around the ligaments or swelling in the muscles. So I think we're going to see more of that. Generally, they don't come in with signs of a kid that has a cord injury. They don't come in with those particular signs. So they don't look like cord injured babies, but I think that these very high injuries that are very subtle can be bad enough to affect their breathing. So, but we're going to get more aggressive with this, and now we're debating whether we ought to be really treating all of our babies as possible neck injured babies.
I just have a follow-up question. If there's no neck injury, but there are the other two elements?
Do you have to have a diagnosis of neck injury to make the diagnosis of shaken babies or abusive head trauma? No, you won't find. In Lucy's study, she found it in 72%, I think, of all the babies that had bad abusive head trauma. And the other thing is that a lot of places still aren't going to use this technique. Doing that special technique where you can save that particular piece of tissue takes hours. And in a busy medical examiner's office, a lot of folks aren't going to take the time to do that. And again, these are not things we'll often pick up on CT or MR or on MR.
My question is on, it sounds like you have years of experience of interviewing these families and parents. While you're interviewing them, I was curious what the parents tell you, or the caregiver, excuse me. Like, do they expect that when they sort of shake the baby, it's just going to kind of quiet them down, they're going to be good to go then? Or do they sort of have like a intention that they really are kind of trying to hurt the baby? Just from your anecdotal experience on there.
I don't think people wake up in the morning and say, "I'm going to hurt my baby today and cause them terrible brain damage." They're overwhelmed, they're frustrated, they get angry, they've got a lot going on, they're having trouble with their relationships, they're getting kicked out of their apartment, whatever, and it just builds up to the point where they just kind of snap. So I don't think people actually plan to do this, but the most common history we get is the baby I just found him that way. I found him, not breathing. And so I brought him to the hospital, and now you're telling me he's got all this blood in his head and so on. Most people, I've had about 30 cases in my career where people have said, "I totally lost it. I shook the baby." And then this one babysitter that said, "Well, I shook him a lot because it puts him to sleep." But most people are going to deny it, at least initially.
So they don't equate like, "Oh, I shook the baby and then I found them later and they weren't breathing"? Is that what you're saying?
They know what they did because the babies get symptomatic. I mean, they get, like, you shake them and they suddenly look horrible.
But they're just telling you, "Oh, they weren't breathing."
What a surprise, baby. And sometimes, the person who actually hurts the baby will just not even do anything, and somebody else finds the baby in extremis. So they're really tough cases. But as in most child abuse, most people don't tell you what they do. I mean, there's a tendency not to fess up, basically, because there's certain consequences.
Any other questions? So I have a question then. If in the case of sudden infant death syndrome, are those cases looked at are they doing autopsies on these kids to see if there was some abuse?
It depends on the jurisdiction. In Washington State, by law, they have to be autopsied. When I worked in Colorado, the coroner system, most of the coroners were undertakers, and if the baby was found dead and they said, oh, we have to do an autopsy, they wouldn't get the business, you know. But if the baby was found dead and they said, oh, I'm so sorry, your baby died of SIDS, you know, then they get to bury the kid and make $10,000 or whatever you make, I don't know. So it really depends on the jurisdiction, but there's a lot of states, particularly in the South, that don't have medical examiner systems, they have coroner systems. And and a lot of these cases go undiagnosed. So when we say 2,000 to 3,000 kids die a year, I'm sure it's way more than that. But those are the ones that are actually recognized. But here in Washington, every baby has to be autopsied.
Kind of along those depressing lines, I'm just wondering what the trend is as far as finding people guilty. You know, is it hard to find evidence? Are people, you know, being prosecuted for these crimes, or is that just, you know, a smaller
Well, I
percentage?
mean, it's very difficult because there are a cadre of expert witnesses who are making huge amounts of money proposing alternative theories that have absolutely no validity, and yet it sounds good to a jury. How do they know if, you know, A is wrong and B is right? It's like I did a case recently in Germany where the child had a horrible head injury, again, a 2-month-old baby, and big, huge bruises on either side of his face, ugly, horrible bruises. And they had an expert witness come and say, oh, that's cyanosis. Now, his lips were pink, his tongue was pink, you know, he was pink all over except for cyanosis over both sides of his head. And the jury acquitted. And so people come in and say these things. Oh, this is a rebleed of a birth subdural, even though we know there's no evidence that happens. Or this is this must have been a child that had a venous sinus thrombosis, and then they got subdurals. Well, you don't get subdurals with venous sinus thrombosis. And people make $10,000 a day doing this, and they fly first class and stay in first class hotels. And they do this hundreds of times a year. Yeah, it's pretty depressing, and we spend an awful lot of time trying to educate juries.
Anyone else? Would you mind if I just pass this to you real quick?
I guess along those lines, just are there other plausible reasons for a subdural?
Oh, yes. Yes, absolutely. Obviously accidental trauma can cause it. Again, it usually depends on it has to be a very severe accident to get very extensive subdurals. You can get subdurals in any disease where the brain is shrinking because nature abhors a vacuum. And so, like, that's why old people get subdurals. You know, Ronald Reagan fell off his horse. 6 weeks later, he had a subdural evacuated. That's because as you age, sorry about that, I mean, I feel bad about that, your brain shrinks. And so you have more stretch on those vessels. So certainly any disease that causes brain shrinkage or brain degeneration can cause it. We have a child here in the hospital several weeks ago, who had glutaric aciduria type 1, shrinking brain, ugly subdurals. But that's because something has to take that space, and those vessels get stretched and they bleed. So yes, there are other things. Copper deficiency can cause it. There's a list of things that we look for, and we test for a lot of that stuff. And, you know, these kids, I think, we spend an awful lot of money doing defensive medicine when we work up one of these kids, because you have to justify what you're doing in court. And people are going to give you a lot of grief if you don't test for rare diseases. So we're very careful.
Carole, do you have any, advice or around the prevention? Any way we can help parents to either know just how bad shaking is? I know we do purple. I know nurses have to train in purple.
Well, you know, the old prevention programs were, let's show videotapes of these horribly damaged children to the mothers in the maternity ward. And that didn't go over well at all. And now I think the color purple was an attempt to try to make it a positive message, you know, that these are things that can these are things that can help you, and these are things that can help you get through those tough times, and don't be afraid to ask for help. And again, I think a very important, a lot of mothers know this, but a lot of their partners don't. And I think that it's behooves any mother who has a baby and they're going to leave them with anybody to grill that person about what they know about the infant head and neck and how vulnerable they are. Because usually the moms are not the perpetrators. That's pretty unusual. It's in all child abuse. But neglect, women are much more likely to neglect children. But in physical child abuse, it's more likely, serious physical child abuse is more likely to be male perpetrators.
One question from one of our video teleconferencing participants. I think you somewhat addressed this question, but I'm going to ask it again. What do you believe is the most important thing the state of Washington can do to help prevent this trauma from taking place?
Maybe you should answer that. We have our chief state of Washington child abuse preventer is in the audience. Do you want to answer that?
Sure. My name is Annette Quayle, and I work with our period of purple crying, which is the prevention of shaken baby in the state of Washington. And so it goes into about 80% of parents that give birth in the state of Washington are supposed to receive this. So hospitals have said. What we find that's happening a little bit is that there were DVDs, now there's an app for it, but that it'll just go in a bag, that gets sent home with the parents instead of gone through with the nursing. I mean, the model is for it to be a teaching moment where they review it, they reviewed the 10-minute video, and then there's kind of a teach back with the nurses. And so we find that not happening, and we do find that abusive head trauma is back on the rise again. It had kind of started to go down in 2008 was a huge rise. And then, so this task force started, then it started to go down, and now we see it going back up again. And we wonder if it's partly not fidelity with the model, that the word actually is not getting out there. So we think, based on the research, of parents really understanding that there's the arc of crying, that in every society worldwide, that babies start at 2 weeks, and the arc of crying goes up and then subsides. So that there's in low criers and high criers, certainly within that, but it's just normal to have more crying. And that what Carole was saying, that we do find that the perpetrators are often more so the boyfriend, not the father even of the baby, but definitely male. And so people understanding, I think, two things, that babies are going to cry more, sometimes you can't comfort them, and the other is just how dangerous the shaking is. I think people don't, intelligent, educated people don't really understand how dangerous that is and the damage that can be done. So I think anything that we can do to educate parents and their partners and kind of just spread it throughout so that people kind of everywhere and that kids would understand that. I think there's a lot more we can do that way.
Thank you. That's good.
Well, yes?
So when you have, sorry, I'm kind of loud. So when you have kids and they're kind of growing up and stuff like that, and you see families that are just kind of play with them rather roughly, like you see, uncles or somebody kind of toss kids up in the air when they're at that toddler age. What's the incidence of like brain injuries from like incidents like that? So like,
well, we've actually, I worked for several years in a biomechanics lab in Japan, and we would model all those sorts of things, and it's just not the same. For one thing, it's not rotational. It's a straight up, straight down, and there's a gentle landing. You have a deceleration that's not abrupt like you do when you hit the back of your head on your spine or on an object. So that's probably not bad. What I find amazing is when you talk to people that do that, you say, well, does the baby like it? No, they look scared or they cry. I mean, toddlers kind of think that's fun. But the other thing is, you can drop them. And I've seen many kids who get dropped. I saw one kid that dad tossed him up into the ceiling fan, and he got the top of his head whacked, terrible skull fractures. So I mean, I think that there's lots of ways to play with kids that don't put their health at risk. And I think that that would be preferable to particularly exciting types of play.
All right, well, we'll end it with that one. And just want to say thank you.
Thank you.